pathology. And today's talk is an interesting talk. It is the normal histology of lymphoreticular system and approach to non-neoplastic lesions by Dr. Anita Ma'am, Lab Director and Consultant Pathologist, Center for Oncopathology, Mumbai. And myself, Dr. Priyavatna, Assistant Professor, Pathology, AIMS Rishikesh, and Dr. Diksha will be moderating today's talk. And the webinar host is Dr. Anita Ma'am and Dr. Sumit Gujral sir. And these are some of the reminders. If you face any connection interruption, low or no sound, please leave the meeting and rejoin with the same link. And please don't send any request for annotation to the presenters. And these are the disclaimers. And the upcoming talks is a slide seminar on Thursday, Approach to Lymphoma by Dr. Yashoda Natkunam. And next week, Tuesday, it is Hodgkin Lymphoma and Mimics by Dr. Sumit Gujral. And with this, I invite Dr. Anita ma'am to start.
Thank you, Priya. Let me share my screen. Okay, can you see it?
Yes, ma'am. Yes, ma'am. It's visible.
Right. Good. Let me make it full screen. Okay, I think you can see that now. It is.
Yes, ma'am.
Okay. Well, good evening then, everybody. It's about, I have to talk about the normal histology of lymphoid tissue or lymphoreticular tissue, if you wish to call it that, and something about benign proliferations that might be confused with lymphoma, or sometimes even confused with things that may not be lymphomas. So I will stick basically to those that are confused, will be confused with lymphomas, but you can imagine that you can have some proliferations that may be confused with things that are not lymphomas. Okay, now we have to start with how do you make a lymph node diagnosis, because knowing normality is very much part of how do you start making a lymph node diagnosis, because when you get a lymph node, you don't know what it is going to be. It's one of those few pieces of tissue or those tissues that you get where just by looking at it, I don't think you can know what is in it. It just, many of these lymph nodes just look swollen, but you really don't know what's inside them. And when you cut them too, unless there is a frank, caseation, or there is frank carcinoma, which you can make out, with the naked eye, it's very difficult on the naked eye to say what is in that swollen lymph node. Okay, so once you have the lymph node, I guess you know how to cut a lymph node. I don't want to get into all of this, because then it just goes on and on. But if you have a swollen lymph node, try to cut it like you would cut you bread loaf it, or you like how you would slice a potato without actually cutting it longitudinally. So you go perpendicular to the long axis if you've got a swollen lymph node. If it's a flat lymph node, most often flat lymph nodes are not pathological. You just get flat lymph nodes sometimes when you are dissecting out lymph nodes in the axilla or in the groin or somewhere else. But most of the time, a lymph node is swollen, and then you cut it perpendicular to its capsule or perpendicular to the long axis of the lymph node. So you get many sections which have the capsule intact. All right, so once you have that and you've got an H&E section, you have to carefully evaluate this H&E section. And I mean really carefully. You should arrive at possible diagnoses, okay? You correlate this with clinical data. You order immunohistochemistry if necessary. If you've got something that you identify straight away, like granulomas or metastatic disease, or something that is so obvious, then you need not do immunohistochemistry. But much of the time, and if there is something that is so obviously reactive and you don't feel you need to prove that it is reactive, then you may not need to do immunohistochemistry. But if this is a serious issue, then immunohistochemistry is often done. Okay, you have to learn how to interpret immunostains, which is extremely important, and then you put all the pieces together to make a diagnosis. Okay, now what do I mean by evaluate the H&E? Now, this means that all the compartments of the lymph node have to be evaluated. And what are these compartments of the lymph node? And I think the compartments start with the capsule. So you have the capsule, you have the subcapsular sinus, you have, I'm sure that some people sitting in the audience will say, oh, we have to look at the cortex, we have to look at the paracortex, we have to look at the medulla. Yes, those are compartments of the lymph node, but as you will see very soon, these are not like, the cortex and the medulla that you see in a kidney. The lymph node is often represented in a diagrammatic form like it is a kidney, because it has this reniform or kidney shape, and you have a convex surface on one side, and then you have something that looks like a hilum. And one tends to, at least many students, when they first come to lymph node pathology, think of this as like a kidney, which has a cortex, it has a medulla, and something that is special in between, and that is the paracortex. But I want you to just think back, and all of you have seen lymph nodes, whether they were removed for, they were swollen, or because you were dissecting lymph nodes from a breast specimen, or lymph nodes from a thyroid specimen, or any other node dissection, or from a head and neck specimen, and just think back. Did you ever notice that there was a cortex and a paracortex and a medulla? And the answer is very likely not. And you can see very clearly over here on the right hand side, okay, which is truly, it is a blown up picture of what is happening on the left and on the left hand side. And you see that we believe that the cortex is something that is full of reactive germinal centers. And the paracortex, we are told, or have been led to believe, is all about the T zone. So we have these nice B reactive germinal centers, and then we have the T zone over there, and then we have the medulla. And you can see that this is not really true. It is a kind of an idealized way of depicting a lymph node. If you ever see one like that, you are very lucky, because the lymph node is an organ which is in different states of physiological reaction, because it is plastic. A lymph node does not remain the same from day to day, moment to moment, or whatever. You have to remember that it is in constant flux. There are two systems in our physiology that are constantly in flux. They have to be, otherwise we wouldn't be they wouldn't be functioning the way that they should be. One is the lymph node or the lymphoreticular system, and the other one is the fibrous system. No, there is repair and regeneration and other things going on. Of course, everything is in flux. You know that the marrow is also in flux, and so also many systems which are regenerating all the time. But one of the most plastic systems from the point of view of normality, so to speak, is the lymph node that you see. So yes, there is something that we might recognize as a cortex, but it isn't anything like what as constant as what you see in the kidney. The kidney cortex is constant. It doesn't change from a moment to moment or from one part of the ear to the other. And then it has a medulla, which is absolutely constant because there is no change in what happens in the medulla unless there is loss of nephrons or there is some other pathology that is taking place. But just look at this picture on the right hand side and you've got we know follicles with reaction centers all the way down into the system, into the lymph node histology. So you have the capsule over there. Yes, you have subcapsular sinus. In this case, it is a little bit, you see that it is a bit congested, but there is no such thing as a cortex. That is very obvious, nor is there a medulla that you see over here. On the left-hand side, you see this is taken from somewhere. This enlarged view is probably taken from this area. But what you notice over here is there is a whole lot of these sinuses, and it looks like there is a whole lot of medulla. Now, obviously, this means that the way that this lymph node has been sectioned is slightly oblique. But I don't think anybody can guarantee that all your lymph node sections will be so well oriented that you will get this capsule, you will get the cortex, you will get the paracortex as you imagine them to be, and that there will be a medulla placed again like it is in the kidney. All right. So you must look at all the compartments of the node, and it's not just about cortex, paracortex, and medulla. It's about the sinuses, the overall architecture. Now, I hear students all the time saying that the architecture is effaced. Architecture is destroyed. Just think about it. All of you have probably used this in your descriptions. Okay? Now, I think you should think very carefully about this so-called distortion of the architecture. And when I ask students, why do you say that the architecture is effaced? They say, oh, we can't see a cortex, or we can't see a medulla, we can't see germinal centers. And that I will put to you is not architecture. Okay? What is architecture is, and I will spend a little time on that because you have to really think about architecture. Like we talk of architecture even in our non-professional lives. Think about the room that you're sitting in right now. Okay, it has got 4 walls and it has a ceiling and it has a floor. That is architecture. All right. Now, I don't know in what room you are sitting, but there could be many similar rooms with 4 walls and a floor and a ceiling. But what's inside the room is not architecture. What's inside the room is content. It is interiors. So you have an architecture, or you have even an architect, and you have an interior designer. So what is inside the room? That same room, okay, could be used as a bedroom. It could be used as a lecture theater. It could probably be used as a seminar room, or it can even be used like where I'm sitting now. I've got a desk and I've got various other pieces of furniture over here. Are you going to tell me that the architecture is effaced if the content of that room is changed? And I think the answer to that would be no. Okay, so just think of a lymph node exactly like that. Okay, a lymph node has got a fixed architecture, and that is the capsule, the sinuses, the the stroma that supports all these sinuses, also the blood vessels that come into the lymph node and leave. Okay, that is more or less the fixed structure of the lymph node. Everything else is content. everything else, your lymphocytes, whether they are B or they are T or the histiocytes, what's in the sinuses, etc., is all content. And what happens more often than not is that the cell content is changed. So it is not an effacement of the architecture, it is the replacement of the cell content. Whatever was there before has now been replaced. Some of that replacement is physiological. Some of it may be, in some cases, it may be pathological. Okay. There are some things that do, some pathologies that do destroy architecture. And those pathologies, if you think about it, would be those that destroy whole areas of a lymph node, destroy the stroma, destroy the the sinuses. And I'm sure that you can think of these things. I don't know if any of you can think of it. Just write it in the chat box, and Priya or Diksha will tell me what you have written in the chat box. But think about it. You have infections like tuberculosis. Yes, tuberculosis destroys the architecture of a lymph node. Okay, that necrosis just goes through the lymph node and takes away everything. It takes away the cell content as well, and it destroys the architecture of a lymph node. So also does a lot of metastatic disease, and in many cases, yes, lymphomas do it as well. Okay, but just think, we don't do anymore. I mean, nobody does it. When I was growing up in pathology, it was one of the things, because we had nothing else to help us. We used to do reticulin stains on lymph nodes. Okay, and just try it once if you want to, and if your heads of departments will allow you to do it. Just take a lymph node which is otherwise normal or physiologically reacting, and do the reticulin stain on this lymph node. Then do it in something that is a lymphoma, and you will be surprised. The lower grade lymphomas will show you very little change in architecture. Though the cell content is changed completely. It is replacing what you would expect in a normal lymph node, but the architecture, the sinuses, they may be a little compressed by the burgeoning cell content, but the architecture, the basic architecture, so the walls may be bulging, the roof may be bulging, okay, but the basic architecture has not entirely been changed or destroyed. So that's one thing that I wanted to tell you, that we should look for distortions in architecture and content. And these may be focal, they may be partial, or they may be diffuse. Now I've put here, you see, something called 2x. I know that most postgraduates cannot decide what kind of microscope they want to use. And even if they do have a personal microscope at home, are very unlikely to have a 2x or a 1x objective, because these are horribly expensive. Okay, but maybe your head of department has a 2x lens that is attached. But I will tell you that trying to do good lymph node examination without a nice bird's eye perspective, where you have a cone which shows you a large area of the lymph node under low magnification, there is no substitute for that, because you can see things that you would otherwise miss, particularly large nodular configurations in a lymph node which are subtle. So this is something that you should all try to do. If there are people who are in practice, who get a lot of lymph node work, particularly something that some sort of lymphoma kind of work, try and obtain a 2x lens. It is worth the money that you spend on it. Okay, now I spent quite a lot of time on this. What's the next thing that you do? Evaluate. We've finished evaluating, or how should we evaluate? Now we arrive at possible diagnoses. So how do we arrive at possible diagnoses? The first thing we do is do a low power examination. Yeah. So that gives you a pattern diagnosis. Is this thing follicular? And that's where your 2x is so important. Diffuse. Is this a sinus pattern where you see the sinuses are stuffed with something, the rest of the lymph node looks okay, or it is a kind of mixed thing with some follicular, some diffuse, maybe sinus plus something that's follicular, etc. So this is the low power diagnosis, and you should note the lymph node is one area in which this is extraordinarily important. All right, then you make a high power diagnosis, okay? And a high power diagnosis is a cytological diagnosis. You need to know whether the cells are small, whether they're large, whether they are mitotically active. Are they lymphoid? Are they histiocytic, myeloid, epithelial, melanocytic, etc.? Now, this only comes with a little bit of experience. Are we seeing a lot of cytoplasm in the cells? Are we seeing, small condensed nuclei? And here comes the estimation of size, okay? Now, I know when I ask people, how do you know that something is small or something is large? Well, you can't use the same yardstick for what is large and what is small if you are doing general pathology, okay? Because you have almost every cell in general pathology, particularly of solid tumors, etc., are large compared to what you will see in a lymph node. The smallness or largeness of a lymph node should be judged by lymph node criteria. And what is the lymph node criteria? You see a lot of small lymphocytes everywhere. No, they're ubiquitous. Okay, so that's what you would use as a criterion. So if something is the size of a small lymphocyte, or maybe twice or three times the size of a small lymphocyte, sometimes maybe 5 times the size of a small lymphocyte, you'd probably call it small. Large cells are 10, 12, maybe even 20 times the size of a small lymphocyte. And the next time you see a Reed-Sternberg cell in a nicely prepared preparation, go and compare it to what the small lymphocytes around them are. And I say Reed-Sternberg cells because you are going to see a lot of small lymphocytes in a case of Hodgkin lymphoma. So just do that, just see. And of course, in between, there are intermediate sized lymphocytes. So yes, the intermediate lymphocytes are not truly intermediate between small and large. They tend to be more small as compared to what we call large cells. The other interesting, important thing is, you will probably hear about it when somebody's talking about lymphomas. We use this term large B-cell lymphoma, okay? And today we have diffuse large B-cell lymphoma, but many of these so-called large B-cell lymphomas are high grade, but they're not necessarily composed of large cells. So some of this you have to, adjust your mind to. Many of them are intermediate in size. I agree that diffuse large B-cell lymphomas are never small cell, but they never necessarily are very large, okay? So many of them are, but a whole lot of them are just intermediate in size. They're very high grade. They come into this group of large B-cell lymphomas, and I'm not going to talk a lot about it because you'll hear about it the next time. Okay, so this is arrive at possible diagnoses. And finally, so I call this a pattern diagnosis, a cytological diagnosis. They're really about observations. Okay, so we're making a diagnosis now. Is this follicular? Is it made up of small and large cells within the follicles? That's telling me something. It means that I'm probably dealing with something that is either a follicular lymphoma or a reactive sort of process, because in my mind, I have made a pattern diagnosis, I've made a cytological diagnosis, and finally, we come to an entity diagnosis, which is about observations, which is what we have done at low power and high power, and each observation has an interpretation. Okay, it's not the same thing. You can't use these two terms interchangeably. At some stage, if if I get an opportunity to discuss the difference between observations and interpretations, we will do it. But for now, observation and interpretation. Now, this is very important. Correlate it with clinical data. You cannot make a benign or a malignant diagnosis on a lymph node without knowing the clinical data, and we hardly ever get good clinical data. Very important is the age. There are some diseases that do not occur, primary lymph node diseases that do not occur in children, okay? And there are some that do not occur in or are less commonly seen in adults, okay? I don't think I would ever make a diagnosis of chronic lymphatic leukemia or a small cell lymphoma in a child of 8 or 10. Okay, that's not a diagnosis that anybody would accept. So then you have to go back and figure out, this looks small, this is a diffuse kind of process. So why is it looking small and diffuse, and this is a 10-year-old kid? Then look carefully, you've probably got bad, bad histology because the fixation was poor, and those small cells are probably lymphoblasts. They all look very uniform and very small when you haven't got well-fixed material. And in that kind of material, because the nuclei are dense, or they have become dense, you may not be able to appreciate mitoses. Okay, so there are these kind of issues that, and only an appreciation of what things can happen at what age will help you to avoid these pitfalls. Now, I'm going to spend a little time on the site. I get requisitions all the time, and I'm sure that you do. This is a cervical lymph node, all right? Now, to me, I never accept that, because the neck is a whole big area. You have the lymph nodes. I don't know who this Priya is, but somebody is requesting to the shared content. And if it is not Priya, is it you? If it's not you, then I'm going to decline.
I'm not, ma'am. I'm not.
All right. So I think somebody has pressed that thing by mistake. Okay. All right. So it's a big area, the neck. You have this. You have all the different groups in the in the neck, which is in the anterior triangle. You have the submandibular, you have the periparotid lymph nodes, you have the upper, middle, and lower jugular groups of lymph nodes, and then you have this area which is the posterior triangle, and you have, and of which one of them is the supraclavicular lymph node. Now, it is extraordinarily important to know where in the neck this particular lymph node that has been removed comes from. If there is generalized lymphadenopathy, we need to know that. Why should we know whether this is where this is in the neck? Well, I'll tell you. I have never found a supraclavicular lymph node, for instance, which is involved by a disease primarily. So there is no lymphoma that, or for that matter, other like metastatic carcinoma, that will only involve the supraclavicular lymph node. If a supraclavicular lymph node is involved, you can bet anything that you want, okay, even your last shirt, if you have to bet it, that there is something going on in the abdomen, or if there is something going on in the thorax, particularly in the mesentery. Never accept that a supraclavicular lymph node is the site of a primary lymphoma. It doesn't happen. So when somebody says supraclavicular lymph node and you're suspecting a lymphoma on histology, please find out what's going on in the abdomen and in the thorax. And if you have some confusion about what's happening, the moment you know that there is something in the thorax or in the abdomen, you will be able to narrow down your differential diagnosis in that confusing supraclavicular lymph node. Then the posterior triangle. There are very few lymphomas that occur in the posterior triangle unless there are other lymph nodes also involved. Just remember that. What happens in the posterior triangle is usually something reactive. So tuberculosis, toxoplasmosis, some reactive lymph node because there is dandruff in the scalp, or some other such reason for why a lymph node is swollen in the posterior triangle. So be a little careful about making some exotic lymphoma diagnosis in the posterior triangle, particularly a diagnosis of Hodgkin's lymphoma, because toxoplasmosis is so common in the posterior triangle. All right. Now, the axilla and the groin. That's another very interesting thing. The axilla and the groin are the sites of nodular lymphocyte predominance Hodgkin's disease, where you will get potato-sized lymph nodes. They're big lymph nodes. Okay, by the time an axillary or a groin lymph node becomes, evident, it's usually pretty large, and you will get a single or a group of potato-sized lymph nodes in the axilla and the groin, and you can just shut your eyes, and of course you have to look at your section, but shut your eyes and make a diagnosis of nodular lymphocyte predominance Hodgkin's. Okay, so this is, again, single group of lymph nodes, axilla or groin, very seldom both, together. Then this issue of mesenteric versus paraortic. Everybody says, oh, this is an abdominal lymph node. Now, I want to know, where is it in the abdomen? Okay. If somebody wants to make a diagnosis of Hodgkin lymphoma and they tell me it is a mesenteric lymph node, I will think twice, because Hodgkin does not occur in the mesentery. It's just one of those things. It does not. So please be very careful about it, and then go check whether it is really a mesenteric lymph node, and you'll probably find that it is a celiac axis lymph node or something. Yes, Hodgkin can occur in any of the paraortic lymph nodes, which often, if they are very large, will present as a retroperitoneal lymph node. But the other lymphomas, T-cell lymphomas, B-cell lymphomas, yes, of course, they can involve the mesenteric lymph nodes. If you have disease in the gut, which is lymphoid, the mesenteric lymph nodes would be involved. But remember this, not to say that you can't get other B and T-cell lymphomas in the paraortic lymph nodes. Of course you can. But Hodgkin, be very, very careful that, you should not, or you should be cautious about making a diagnosis in a mesenteric lymph node. I've already talked about localized versus generalized lymphadenopathy. Is very important. I tend to be very cautious about making a diagnosis of a T-cell lymphoma, one of the common T-cell lymphomas, if it is not generalized. Anaplastic large cell lymphoma, which is a T-cell lymphoma, yes, can be localized. But if you want to make a diagnosis of AITL or any other T-cell lymphoma, just be a little careful if it is a single lymph node that is involved. A similar story for follicular lymphoma. They tend to be generalized. Also, we should know whether the spleen and the liver are involved. We need to know the duration of the lymph node. If you've got a lymph node that has popped up in a matter of a few days, and somebody has biopsied it for a variety of reasons within 10 days to 15 days, it's unlikely that this is anything serious, okay? Particularly if it doesn't look, it's monomorphic. If it's not monomorphic, then you have to be a little careful. Then all these accompanying signs, and drug history is important, because drugs can modify what is going on in a lymph node, and we should know, and some drugs themselves can produce lymph node hyperplasias. Everybody talks about dilantin. I think I have only seen maybe one drug that has produced once in my life, and I think maybe that's the one that Sumit once showed me about dilantin-induced lymphadenopathy. But yes, I have seen lots of drugs that produce peculiar reactions in the skin, and those are T cell predominant, and they can be really difficult unless you know that this is a drug reaction. So if you're talking about lymph nodes, it's not very common, but yes, in the skin, a drug history is very important. Comorbidities, immune disorders, we need to know about. All right, so order the immunohistochemistry if necessary. I told you if it is TB or something else that is very obvious, we don't need immunohistochemistry. But today, you make a diagnosis of Hodgkin's, it is barn door, open and shut, Hodgkin lymphoma. Nobody is going to accept that diagnosis unless, immunohistochemistry has been done, unless you are in a situation where you don't have immunohistochemistry and you can recommend that it be done. And you'd probably be right if you have made your primary diagnosis of Hodgkin lymphoma, because there are so many mimics, and I'm pretty certain that you'll have a really nice talk by Dr. Gujran on the mimics of Hodgkin's lymphoma. It is one of the more difficult areas in histopathology, and I can quite imagine that in the days when we did not have immunohistochemistry, we probably every now and then called something a Hodgkin lymphoma when it was something that was a mimic. Okay, you have no, you can't feel sorry about these things. But today, I think that one should, have immunohistochemistry to make that diagnosis. No matter, you can make it on H&E. We need this to immunophenotype. I know that this is a lymphoma, and I know that this is a large cell lymphoma. It's nothing else. But these days, we don't treat B cell lymphomas the same way as we treat T cell lymphomas. That might have been true once upon a time. Today, you need to know whether something is a B cell lymphoma, so we need to immunophenotype it, not just to say that it is B or T, but to subtype it as well. And as far as an uncertain diagnosis, you have no choice. You will have to do immunohistochemistry. Okay. Now we need to interpret immunostains, and this is where it's important that we have a knowledge of the normal patterns of expression in the different compartments and stages of differentiation, because there are stages of differentiation, and I'm sure all of you have been through immunology and you know that you have a vertical differentiation pathway, and you have a pathway that is horizontal differentiation, where it's a post-antigen pattern of differentiation that is present. You need to know also the expression in the cell compartments. And what do I mean by cell compartments? That is within the cell. Your immunostains, where are they expressed? Or the antibodies are picking up antigens that are nuclear, cytoplasmic, or membranous. This is very important. It's not just about brown being anywhere and you just score it as being that way. Now, you also have to know the variations under neoplastic and reactive conditions. In other words, aberrant expression and non-expression. And you'll hear about this, particularly when Dr. Natkunam is talking about that CD5, for instance, is a T cell marker. But there are some B cell conditions in which CD5 is expressed. Okay, so I think we need to be aware that under neoplastic and sometimes under reactive conditions, you get aberrant expression of markers which you have to be aware about, otherwise you're going to fall into some kind of pit. Okay, and this last thing I will say that clonality assessment is only possible on immunohistochemistry in some B cell lesions. Okay, T cell clonality requires gene rearrangement studies, or today flow cytometry. Flow cytometry can certainly tell you a lot about a particular clone, and can even pick out small clones that are which we may not be able to detect on histology, or sometimes in gene rearrangement studies, we may not be able to do it. And I think flow cytometry is very complementary to what we're doing. Now, this clonality assessment, when we talk about in B cell lesions, it means essentially looking for light chain expression, usually, whether it is a kappa restricted lesion or a lambda restricted lesion. Plasma cells are really most amenable to this kind of thing. Immunoblastic lymphomas are very, very amenable to this, because there's a lot of cytoplasm and there's intracytoplasmic immunoglobulin. Okay, so there's a lot of it. When you have immunoglobulin which is being expressed on a surface, that becomes a little more difficult to do on immunohistochemistry, unless your immunohistochemistry is really A class. It's not always easy to do that, but routinely we just look for intracytoplasmic light chain restriction. Sometimes we look for heavy chains. You may not find any light chains at all, and then that's a bit of an issue. And then you can look for heavy chains, in which case you can do IgG, IgM, IgA, and all of you have heard of heavy chain disease. The most one that everybody gets very excited about is the IgA heavy chain lymphoplasmacytoid lymphoma that is present in the gut, which was once upon a time known as the Mediterranean lymphoma. There you find no light chains at all. This is just a heavy chain disease. Light chains are not big. So if you're looking for clonality and you're doing only light chain immunohistochemistry, sometimes it's not going to answer the question. You may have to look for heavy chains. Okay, right. So now let's look at how this immunohistochemistry is done and how it is expressed. Now here you have this lymph node, as I showed you. Okay, and you can see that I have really taken the immuno, or photographed the immuno profile for CD20. You can see that it's here. And as I told you, it's not very easy to talk about the cortex and the medulla. Okay, where would you actually draw a line to say this is the cortex, that is the medulla, and in between is the paracortex? In fact, what you see, I hope that my cursor is visible. I'm not sure. Do you want me to do something with a laser pointer? I don't know whether that's better. Yeah. If it's better, is it better?
Yeah.
Yeah. Okay. So then what you see over here is, you see obviously this is CD20. So all of that which has picked up the, the brown stain is CD20. You find a very dense stain in the mantle. You find a little less dense stain in the terminal centers. But notice something, that there is something here that looks as if it is a little nodule or maybe a follicle, and it's not stained at all. Yeah. When you go to CD3, and here you have in the bottom left-hand corner is CD3, you see what that nodule is? It has picked up CD3. So here is this a CD3 positive area, which looks terribly nodular. You also see something very interesting in this CD3 positive area, that there are these negative sort of tubular structures. They're actually blood vessels, and these are the high endothelial venules in the T zone, which are not obviously picking up CD3. You see them stand out as a negative structure, but just notice that the area that was CD20 positive is negative, except for here and there a few CD3 positive cells that are in the germinal centers. So now here you are able to see something that is the cortex, which is this area, and that which is the T area, which is the paracortex. Okay, some people would call this a composite follicle. I think it's a bit ridiculous, because we we talk about follicles only with respect to our B cell areas. But yes, I think we are becoming more and more, we are recognizing that there are other cells besides B cells that can form follicles. You hear about it when they're talking about lymphomas. But those lymphomas that we are talking about are the lymphomas that are of follicular helper T cells, those that are sitting within the B cell follicles, and not these, sort of T cells which are present in the paracortex. So now I hope you have understood that we have, this is a little cortex, that is the paracortex, and it is not this broad area, or it can be very broad, and I will show you that what this actually is. Now on the right hand side is MUM1. Okay, MUM1, I've just put it over there, but MUM1 is a good marker of plasma cells. Okay, it's a good marker for many other things. So it is a good marker for melanoma. Okay, but in the context of lymphoma, if you've got a lot of plasma cells, or for that matter, MUM1 also is expressed in some lymphomas, also in Reed-Sternberg cells, but in routine, regular, normal lymph nodes, it is expressed in plasma cells. And you see all this in this area, you see that apart from the pink things are the sinuses, but the rest of it is the medulla. And look at the medulla of this lymph node, okay? It's just stuffed with plasma cells, which is where the plasma cells should actually be. Okay, so that's MUM1. Good. Now let me see. Why is this not moving? Good. Now let us look at this picture. Okay. On the left-hand side, this is CD20. And now you understand why people talk about cortex and paracortex and medulla. This is a lymph node that has been beautifully, and I think by accident, sectioned. I've shown you the H&E, but I don't need to. You can see this whole little array of a beaded kind of array of follicles that is present just below the capsule, which is B in origin, yeah, which is all B cells. That's the cortex, and a completely unstained area in the CD20, which is your paracortex. And then you have this medulla, and in that you will probably have some B cells and plasma cells, and sometimes plasma cells, very rarely, but sometimes if it's a heavy stain, might even pick up CD20. Okay, abnormal plasma cells do that all the time. Now here is CD5. Now CD5, as I told you, is a T cell marker. And this CD5, this is, kind of a mirror image where you can see that it has not marked that beaded follicles in the cortex, but it has marked very heavily all the T cells in the paracortex, and you see next to none being present in this medulla. So this is a beautiful negative positive image. I could replace that CD5 with a CD3 and it would show you exactly the same thing. All right, now you can look at the same thing in CD79A. Now CD79A and CD19 are markers that we don't use very routinely in our lab, but we have it. We use CD20 all the time as a B cell marker, but sometimes it's very interesting to use 79A because today a lot of patients are being treated with rituximab when they have a B cell lymphoma. And when you have treated with rituximab, which is a monoclonal antibody against CD20, sometimes when the lymphoma recurs, the CD20 has been downregulated, okay, because rituximab has cause this downregulation of CD20. And you might even feel that this is not a CD20 expressing, or it's not a B cell lymphoma at all, because you cannot demonstrate CD20. In such an instance, CD79A or CD19 will mark what CD20 is failing to mark. Also, you can use something like PAX5, which is a factor, which is a transcription factor, to show that those cells are actually B cells, but they have lost expression of CD20. Okay, so this is 79A, and once again, you see this beaded kind of appearance. Now here is BCL2, and I'm sure all of you know about BCL2. BCL2 is a marker that we use more often than not to say whether a follicle is expressing it, and if it is expressing it, then it is unlikely to be a normal germinal center. If it is not expressing it, as it is in this case, this is a reactive follicle, and reactive follicles do not express BCL2. And I can't go into the physiology of each of these different things, but you know that that is true, that apoptosis is happening inside the follicle, and BCL2 is an anti-apoptotic factor, and therefore it is not being expressed in normal follicles. And you can see that here. You can see in both on the left and the right hand side. You see the tingible body macrophages, which are the unstained areas, almost like a starry sky appearance within the follicles, and BCL2 is not expressed. Every other part of this lymph node, all the other lymphocytes, if they are lymphocytes, the mantle zone, the T areas, all will express BCL2. It's only the follicle centers that do not express BCL2. And those follicle centers, you know, are follicle centers. Why? Because they should express CD10. Okay, so remember this, CD10, if you're seeing CD10 and it is within a follicle and BCL2 is being expressed, then that is significant. That means that you are dealing with a follicular lymphoma. Okay, but if you see CD10 being expressed and there is no BCL2, then that is very unlikely to be a follicular lymphoma. All right, there are lots of exceptions to all the never and ever and all that, but that's what biology is all about. But this is what a reactive follicle, very, very nicely showing your idealized version of what is a cortex and what is a paracortex. Okay, oh, come on, why aren't you? All right, now here, just to show you what I was saying before, here you see that there is a mantle, which is quite dense, all small lymphocytes. You have got a germinal center where the lymphocytes are larger. And if you look very carefully, you can see that there is a zonation. Okay, there is a darker area and a lighter area, and you can see the tingible body macrophages. Now let's look at the immunohistochemistry of this. Do a CD3, and what do you see? That there's a sprinkling of CD3 within the germinal centers. Okay, you can see that. It's very clearly seen over there. Why is it important to know how many CD3 cells are present in the germinal center? Because if I have a lot of CD3 that is in the germinal centers, I might have CD10 as well, but there is a lot of CD3. Imagine if I do a BCL2, okay? Those CD3 positive cells, which are T cells, they're normal helper T cells in the follicles, will pick up BCL2 because that's what they are supposed to do. They have got nothing to do with, they don't undergo apoptosis, so they don't shut down their BCL2. And then you might feel, oh gosh, this is all, the follicles are BCL2 positive. So I think it's always a good idea if you see a follicle that seems to be BCL2 positive and you want to make a diagnosis of follicular lymphoma, just go and see how much CD3 there is in the follicle. There is another important thing that about how BCL2 may be positive in follicles, but we'll come to that a little later. Here is CD10, and that's how the germinal center should look like. It should have a lot of CD10. And if you're looking at CD3, what is the CD3? The cells, what are they? They are CD4 expressing. See, CD8 is negative in these follicles. So these are follicular helper T cells. That's why we call them follicular FHTs. And today there are lots of lymphomas that we have to remember when there are follicular helper T cells. But that's not my brief, so I'm not going to talk about it. Once again, here you can see the follicles. Sometimes, we are used to thinking of the mantle being, all around. No, the mantle can be like a crescent. Okay, it can, obviously, this is a reactive follicle. I just showed this to you because you can see that BCL2 is negative, except for the T cells that are there inside that follicle, which are picking up that BCL2 as little dots in the nuclei. But the mantle is often IgD, not often it is IgD positive, or sometimes the cells are IgM positive. The mantle is also BCL2 positive, as you can see over here. The mantle, I think, people, please don't ask for annotation. I know you're doing this by mistake because you're pressing something that has got a little squiggle, but it's just disturbing to me and to other people. All right, so here you have the mantle. So the mantle is BCL2 positive, please. Everything except for the CD10 positive cells in the follicle center will be BCL2 positive. So just remember that. Also, I told you that there is a zonation within the follicle center. Okay, and this is a Ki67, and you see that the lighter part of this will show you less Ki67, and the more denser area shows you a lot of Ki67. So this is one area which is very proliferative, and you know what is going on in germinal centers. There is this, there is a differentiation of cells. You need apoptosis to be allowed in a germinal center, because this is where there is a hypermutation going on, and the antibodies are being, those cells with appropriate antibodies are being selected. If the antibody is inappropriate or is not a good fit, then that particular cell and its clone undergo apoptosis. Okay, right. Now, why am I not being able to go to the next? All right. So now let's go a little further. You have in the germinal center, you just don't have B cells and T cells, and the B cells are CD10. You also have a dendritic cell network, and this dendritic cell network is follicular dendritic cell network is an antigen presenting network for the B cells. Okay, so here you have CD23, and you see how exactly like a network it is. You may not be able to appreciate this very, very well over here, but sometimes you're lucky, and you will see that the mantle also takes up CD23. Okay, that's just a normal pattern of reaction, but you should know that and not get sort of confused. Then, of course, in the B zone or in the T zone, not within the follicles, but outside in the interfollicular zone, you see immunoblasts, and you can see this CD30 positive immunoblasts. They have a membrane stain, and you can see the Golgi. The Golgi is this little dark spot that is seen within the cytoplasm of the cell, and you can see it there, you can see it there, you can see it here. So that is CD30. And I showed you the the plasma cells. I showed it to you with the MUM1 stain. You can do 138, will also pick up the plasma cells. And this is how you can stain it for kappa and lambda light chains. You can either use immunohistochemistry, or increasingly, at least in my lab, we are using in situ hybridization. It gives you a more specific and a brighter kind of stain. And this is the kappa to lambda ratio. It's absolutely normal. So if you wanted to say that the kappa to lambda ratio is really high, it has to go, 8:1 or 10:1 or even more than that for you to say that there is a kappa light chain excess, or even to say that there is kappa light chain restriction. Okay, so now we have to interpret immunostains. And what do we mean by that? I mean, I've shown you all the immunostains. So what is to be interpreted? All the assessments, number one, have to be made on the population of interest. There's no point in saying this is a CD20 excess or a CD3 excess. You have to decide what is that population that is of interest to you. And I mean specifically in lymphomas, okay? Because no lymphoma is a pure lymphoma. You must remember that. Very seldom do they show you a pure population. There are some exceptions, as if you've got a lymphoblastic lymphoma, you've got a Burkitt's lymphoma, you're not likely to see anything else but the neoplastic cells over there. But our run-of-the-mill lymphomas are an admixture of B cells and T cells, and let me tell you, it is sometimes exceedingly difficult to tell which is the population of interest. But whatever the situation, please remember that lymphomas may be in a minority in the population. Hodgkin disease is one of them. Okay, T cell rich B cell lymphomas. What is it? The very word tells you that it is full of T cells. You have to really look for the cells of interest. They are usually larger than the other cells, but don't bet on it. That you just need a little bit of experience to be able. Fortunately, these are not very common occurrences. But I will just tell you that there is no place for percentages or plus. Okay, and I'm sure that the hematopathologists, including Sumit, who's here, will tell you that this used to be, or for all I know, there are still some places that even tell you on flow cytometry that we've got this percentage of cells that are this and this. I think that you have to identify the population of interest, whether you're doing immunostains or you're doing flow. And it's that population of interest that you should actually investigate further. I hope I've said it right, Sumit. Is that true also of flow?
Yes, yeah. We don't give percentages, we just
exactly. So if you're not doing it on flow, I think that it is ridiculous to do it on immunostains, okay, for lymphomas. Okay, now I just want somebody, I'm sure that there are some people in the audience, and before you go to sleep, just tell me what immunostain is this. Just put it in the chat box, and either Diksha or Priya, tell me what they're saying in the chat box.
Sure, ma'am.
Yeah, what are they saying in the chat box if anybody's answering and if they have not gone to sleep?
CD10.
BCL2 and CD10.
So they're
BCL2
saying
and
it is CD10 and
BCL2.
BCL2. Okay. Well, let me tell you that both of these are stained with BCL2. Okay. If I tell you that both are stained with BCL2, now tell me, what is this disease? Now, what is on the left-hand side and what is on the right-hand side? Okay, this is BCL2, and you can see the difference between what's on the H&E on the left-hand side and
Mantle
the
cell.
H&E on the right-hand
Follicular
side.
lymphoma, mantle cell.
Yes, and what you can see is that there are tingible body macrophages on the right-hand side. You also see, there's a T-zone over here, which is, you know that it's a T-zone because you can see that there are these high endothelial venues all sitting around over here. Here, there are no tingible body macrophages. But this is one of those situations in which you're not sure. I can see follicles. There is some condensation of mantles. So I must do a stain to prove whether or not there is, this is a follicular lymphoma or a reactive follicular hyperplasia. And there are two stains that help you. Okay, one is BCL2. And here you see BCL2 is expressed. So this is a follicular lymphoma. It's nowadays we don't grade 1, 2, but whatever. And this is follicular hyperplasia. There is another stain that is important and many people don't use it. And that is Ki67. Okay. If you use Ki67, which is a labeling, it's a proliferation labeling index, you will find that it's very high in follicular hyperplasia, because this is where proliferation is going on. Proliferation and apoptosis is going on inside that center. So you get, as I showed you in the Ki67 stain just now, a little while ago, you will find it, upwards of 90%, sometimes, okay, maybe upwards of 80%, but you will find a very high proliferation index. When you've got a low-grade follicular lymphoma, and this looks low-grade, I mean, these are not, high-grade looking cells, your follicular, your Ki67 will be low. It is like 10%, 15%. You can never get 10 and 15% in a normal follicle. So that is something that you must remember if you are trying to investigate whether there is a follicular lymphoma or a follicular hyperplasia. Now I'm going to ask you guys, and someone better write it in the chat box. Okay, now this, of course, this idea I got from Sumit to show follicles and their mantles by taking a sliced, hard-boiled egg. So Sumit, you have to take credit for that. But the only thing is that I have the sliced eggs all put like this, like we are slicing a lymph node, okay? Or slicing a follicle. This is not a lymph node. This is you're slicing a follicle. And that is the mantle zone. The white is the mantle zone, okay? And the yolk is a reactive germinal. This is a reactive lymph node. So what expression, now I will ask you, do you expect in the zones that I will point out to you? All right. Now, what expression of BCL2 will you find in a reactive germinal center? That should be very easy. Now, come on. What's written in the chat box?
Negative.
Negative. Excellent. Now, what will you find in this zone over here? Somebody?
Positive.
Positive.
Positive. Absolutely. And you do realize something that you should realize. This is the end of the follicle, right? It's when you have a spherical structure with a center, the center doesn't extend to the periphery. You must remember that. So if you have sliced it so that there is a peripheral area, what you are probably getting is just the mantle. So it does look like it has a circular outline. It has a somewhat spherical outline. And then you will find BCL2 positive. And then you'll say, oh, there is a follicle here that is BCL2 positive, and God knows you might even call it an in situ follicular lymphoma. Now, that you should not do, because there's a reason why you should not do this. You should remember that the ends of the follicles, when you are slicing it, perpendicular to the surface, are going to have just mantle cells. And this is positive because it is composed of mantle cells. All right. What about this? Anybody? Come on. What would the expression of BCL2 here be? What are you saying? I saw Saurabh, Gautam, Kavya. Somebody RS saying positive. Excellent. So the lesson has been learned. Okay, it's positive. What about CD10 over here? What should it be? Come on, guys. What should it be? Positive. Excellent. Right. What should it be here? CD10. And this arrow. What should it be?
Negative.
Negative. Excellent. All right. What about the next thing? CD3. What should it be over here?
Negative.
Negative. Is that answer absolutely correct?
Somebody has written occasional and sprinkle as well.
Very good. That is the answer to that question. It is positive in the follicular helper T cells. It is never completely negative. Okay. What about CD4? What should the answer be over here? CD4.
Sprinkling.
Focal.
Same thing. It is positive in the follicular helper T cells. Yes. What about CD8? What should it be like?
Negative.
Negative. Excellent. Very good. I don't know who's answering the questions, whether it is Diksha or who, but CD5. What is the answer to this question? What should CD5 be in, which is essentially the mantle zone? What should it be? I see a lot of positive, positive, positive. And the answer is no, it has to be negative. Okay? Because CD5 is a T cell marker under normal circumstances. There are no T cells in the mantle, right? If there are T cells, they are in the follicle centers. When you get T cells, CD5 being expressed, not T cells, but CD5 being expressed in a mantle, then you should worry. This is probably an early mantle cell lymphoma, okay? Because CLL and mantle cell lymphomas are B cell lymphomas that express a T cell marker, and that is CD5. So CD5 should be negative in the mantle. All right. What should CD5 be in the germinal center? Come on, folks. What should it be like in the germinal center? Everybody's saying negative, negative, negative.
Positive.
Somebody said positive. Somebody said focal. CD5 is a, come on now, what is it? It's a T cell marker. So if CD3 is going to be positive in follicular helper T cells, why shouldn't CD5 be positive in follicular helper T cells? Of course it is positive. So it is positive in follicular helper T cells. Okay, so this was just a recapitulation of what I have just told you. You don't have to remember this, you have to understand it, okay? And what do you have to understand is this, okay? In a follicle, because now we're looking at a follicle. And what is a follicle? It is got a mantle on the outside, and it has got a germinal center in the center when it is reacting. All follicles are not reactive. You can get a follicle composed entirely of mantle cells, and those are known as primary follicles. There is no stimulation of a germinal center, which happens when there is an antigen to which this B cell follicle, it has got CD23, it has got the mantle cells, because a follicle cannot form unless you have the follicular dendritic cells, okay? They help the B cell areas to actually form follicles, okay? That's the function of CD23, apart from the fact that it will express, or sorry, it will present antigen to the B cells and the helper T cells, okay? So in a follicle, please, please, please do not evaluate BCL2 in a CD10 negative zone. I hope you've got it. The follicle centers must have CD10. Only then you can evaluate BCL2 and say whether BCL2 is positive or negative. If there is CD10 in the follicle, and the previous case was a case in point in which you would have had CD10 in the follicles, and only then you should evaluate BCL2. If CD10 is positive in the follicles and BCL2 is positive, then you have got a follicular lymphoma. If CD10 is positive in the follicles and BCL2 is negative, look around, you've got tingible body macrophages and everything else, then that is reactive follicular hyperplasia. But the biggest sin is to look at BCL2 and not have looked at CD10 before that, because primary follicles, which are only made of mantle cells, or the ends of follicles, okay, like I showed you over here, okay, there will not be any CD10 over here, but there will be BCL2 because they are only mantle cells. I hope you guys have got that thing right. Very good. Now, another thing, in a follicle, and you guys fell into the trap, if it should be 5, I'm sorry, 5 is missing in that. If CD5 is positive in the mantle zone, this is abnormal, and mantle cell lymphoma is a possibility. Okay, so I'm not saying that it is mantle cell lymphoma, but that is abnormal. I hope that is something that you now internalize. Very good. Now we come to how to evaluate an atypical lymphoid process. And the first thing is rule out a malignant process. And you'll say, how do I rule out a process? Well, I told you before, you have to evaluate all the compartments. You have to do your homework with regard to immunohistochemistry. You have to look out for the cells of interest and look at them clearly. And that will, in more cases, that means 7 out of 10 cases, you will be able to rule out a malignant process. And to do that, you must be familiar with reactive patterns of proliferation. And there's not just one reactive pattern of proliferation. There are many. And so therefore, you have to ask yourself these questions. Number one, is this a lymphoma? Yeah. Okay. So that's when you're doing all the stains, that is rule out a malignant process, because up to now, we believe that when you use the word lymphoma, it's malignant. It could be something else also, which is not a lymphoma. It could be a metastatic disease. It could be melanoma. It could be other things. But you have to ask, is this a lymphoma? The next question is, if it is this Hodgkin or non-Hodgkin's? Of course, there are all sorts of combinations of the two, but this is what you need to do. And finally, what is its subtype? So that is, if you have reached the conclusion that it is a lymphoma, this is what you need to do. Now, is this a lymphoma? Well, how do you do that? Is this a benign reactive lymphoid process? That's number one, which is being mistaken for a lymphoma. Number two, is this a malignant tumor other than a lymphoma? Could this be a myeloid sarcoma that is in a lymph node, an extramedullary myeloid cell tumor in a lymph node? Could it be a carcinoma that is looking like a lymphoma, or I don't know, like an ALCL? An ALCL can look like a carcinoma. It can look like a melanoma. Sometimes it doesn't remind you of a lymphoma at all, right? So this is, therefore, we come now to the next part of my talk, which is the masqueraders, okay? The ones that masquerade as lymphomas, because I was also supposed to talk about benign processes that might be mistaken for lymphoma. Okay. And the masqueraders are of 3 types, and I'm not going to talk about tumors that simulate lymphomas and lymphomas that simulate other tumors. I'm only talking about benign lesions that simulate lymphomas and vice versa. Okay. So why do they simulate lymphomas? Because there are common patterns in lymph node histology that resemble lymphoma. And what are these common patterns? And I'm sure you have all come across them. These are polymorphous proliferations with or without large cells. And the benign things are viral lymphadenopathies. Sometimes you might also have some metastatic carcinomas, which are just focally involving a lymph node, like one of these variants of undifferentiated carcinoma of the nasopharynx. I never remember which one it is, Reagan or Simke or whatever, but you may get that sort of pattern which simulates T-cell rich B-cell lymphoma or simulates Hodgkin lymphoma. But which are the lymphomas that you can mistake them for? Well, Hodgkin lymphoma and PTCL, because peripheral T-cell lymphoma is, unlike the B-cell lymphoma, very polymorphous. They have some small cells, they have intermediate sized cells, they have large cells. You often have immunoblasts or immunoblast-like cells, Reed-Sternberg-like cells, etc. And you don't know then whether you're dealing with a viral lymphadenopathy or you're dealing with a PTCL. Then you have the follicular and nodular proliferations. Okay, and that we just talked a lot about it. That's follicular hyperplasia versus follicular lymphoma or nodular lymphocyte predominance Hodgkin's, because those are the follicular nodular type of proliferations. Then you have focal areas which have atypical cells with or without necrosis. And the one that really bothers us a lot, because in this country, as against the Western world, we see a lot of Kikuchi disease. And Kikuchi disease has many different phases. It might partially involve the lymph node. It might show you this very proliferative type of area in which the apoptotic debris is very, very focal, because you have so many histiocytes and you have the plasmacytoid dendritic cells, and you may be hard pressed, to tell whether this is a lymphoma or not. Okay. Then you have mitotically active proliferations like ALPS, that is acquired, this lymphoproliferative syndrome, in which you have autoimmune lymphoproliferative syndrome, in which the lymphoid cells are unable to undergo apoptosis. So they're proliferating, they should be undergoing apoptosis, and this is a T-cell disease. And that whatever it is that stimulated that T-cell proliferation has probably died down, but the cells are unable to undergo apoptosis. And it can look very much like a high-grade non-Hodgkin's lymphoma, lymphoblastic, or even a Burkitt. Right. And finally, you have this diffuse or sinusoidal infiltration of undefined cells. Could be histiocytic disease, metastatic carcinoma, and ALCL, is a sinusoidal disease. So let's just look at some examples of this kind. It's not possible to go through all. Okay. Now here is a lymph node, and I'll first show you the histology, and then we'll go to the clinical picture. The clinical picture is absolutely important. Now here, if you notice something very interesting, you can see this subcapsular sinus. You look at, this is the low part, and you see all the sinuses. The sinuses are congested and they have RBCs in them. Normally we don't see RBCs. So this is an extravasation of RBCs. They're so congested, and these are not blood vessels. These are lymphoid sinuses. But that's what you notice in many cases of this kind. Okay, they have a lot of blood in these sinuses. You can also see that there is extravasation of RBCs within the lymph node. The other thing that you notice is that you can't see any good follicles with germinal centers. There are some vague things here and there, and are they really follicles with germinal centers? You see large areas of cells, and yes, you feel, oh, perhaps there are follicles with germinal centers, because I see some tingible body macrophages, but they are not defined. They have not settled down to become proper follicles with a mantle and a germinal center. And then, of course, you see these very large cells with nucleoli. You can see them all over here. They are clustered in some parts, and you see what look like histiocytes. They could actually be dendritic type cells, which are in the interfollicular space. Okay, now I'll tell you what the case history is. This guy was a 29-year-old male to be married in a month's time. Okay, he had lymph nodes in the neck of 2 weeks duration associated with a sore throat. Now, he went and saw his GP. He's going to get married. The GP is told to do something so that he gets better and he can, buzz around and get ready for his wedding. He's got lots of things to do. So the GP gave him an antibiotic. This is such a common story. Antibiotics are given for anything. And he broke out into a rash after the antibiotics. Since the lymph nodes did not subside, then a biopsy was done. And the block was sent for review because somebody called this mixed cellularity Hodgkin's lymphoma. Okay, so now let's look at his immunohistochemistry. And what do you see? You see what we saw, no? And that much of what is present in this lymph node is not B. It's all T. Can you see? There are some very, there are lymphoid follicles, and you know that this is a lymphoid follicle because as we showed you in the first immunos that I was showing you, that you get a sort of dense periphery and you get a lighter colored center. So this is a lymphoid follicle, and you can see that even in the CD3, but the mantle has not settled down around like what you should see as a enucleatable follicle, so to speak. This disease is not just within the lymph node, it is also outside the lymph node. It has gone into the fat, and even there it is mainly a T cell sort of thing. You can see here that was CD3. I'm showing you CD5, and look at the CD30. And I can understand why somebody thought that this was Hodgkin lymphoma, because there was a lot of CD30 in this, and obviously that individual was not able to go any further, but with the lymph node having been biopsied, and it is showing you a T cell reaction or T cell background, and then you're seeing CD30. Okay, well, this was not, I'm sure you know what this is. Okay, here's the CD20, and you see that those big cells are not just CD30 positive, they are CD20 positive, you can see that, and they are also LCA positive. Nobody, at least now in my lab, I know do LCA, but at the time when I saw this case, I did LCA. Okay, so if they are LCA, those CD30 positive cells are LCA positive, and they are also CD20 positive, which is very odd for Hodgkin lymphoma. So we did something else. Okay, and now somebody write in the chat box, what is this stain that has been done on the bottom left-hand corner? And it tells you exactly what this is. Yeah, everybody's talking about, yes, it is EBERS. Okay, this is Epstein-Barr virus stain. And you notice that, yes, it's EBV, that's what they're saying, yes. So it's there in larger cells, and it's also present in smaller cells that you see in the background. And so it's not just in those large cells, which would make me, uncomfortable, because then it would negate the diagnosis that I was thinking about. And so what is my diagnosis in this case? Yeah, it is infectious mononucleosis. And I want you to note that it was classical in every way. Sore throat, which after antibiotics, the patient developed a rash. You find out what that antibiotic was, and you will it will be something like augmentin or something that is a penicillin derivative. Okay, it's a higher antibiotic which is derived from penicillin, and these patients break out with a rash. Don't ask me why, but this was something that I learned many years ago, and I ask this of patients when I have a problem, and then it solves the problem for me. Okay, there is disease beyond the capsule, there is poor demarcation of follicles, no well-formed mantles, because these are acutely reacting follicles and a huge T cell proliferation. That happens. It happens in infectious mononucleosis. It's not just a B cell reaction. And then you have these clustered CD30 positive immunoblasts. And we know that they are immunoblasts because they express CD20. And in this case, are also expressing LCA, which is CD45. And there, of course, there are EBERs in both large and small cells. Okay, so this is infectious mononucleosis. Can be a difficult problem if you don't get a good history, which doesn't preclude the fact that you should try and get a history. And please, I say this to many people, if you find this kind of congested sinuses, it may not be infectious mononucleosis, but it's a viral condition. You should be almost certain that it is a virally reacting lymph node. Okay, so now let's go to the next one over here. And here you see a lymph node. It looks a bit diffuse. This is a very low power view. Okay, it looks diffuse. When you come to a little higher power, you begin to say, yeah, there are a few sort of follicles, but again, mantles are not well developed. Yeah, you're seeing something that looks like a mantle, but you know, this is all small. These areas are small. You can see some reaction centers, but here is a lesion. You can see the mantle very on the top right hand corner where you see my cursor. The mantle is there, but what's inside? This is not a reaction center. In fact, what you see are probably these follicular dendritic cells that are unaccompanied by the follicular center cells. So follicular center cells missing, there is a follicular dendritic cell over there, but let's see what we see and then in the interfollicular space, you see, reacting large cells, you see small cells, you see a very polymorphous picture. Okay, so now I'll tell you the history. It's a 28-year-old male who had anemia, splenomegaly, cervical, that means generalized lymphadenopathy of 6 months duration. As usual, the GP put him on anti-tuberculous treatment and he had no effect. Then somebody decided to biopsy his cervical lymph node. Now this is a reasonable thing to do, meaning if something does not subside in 6 or 8 weeks on its own, then biopsy the lymph node. Biopsying something within 6 to 8 weeks, and like that patient with infectious mononucleosis, I think if he wasn't getting married, then he would probably not have been biopsied and that whole reaction would have disappeared. Okay, but within 2 weeks, he was biopsied and then he got this fright of his life because he was now told he had Hodgkin's lymphoma and he had to make up his mind whether he had to get married or not get married, as the case may be. Now here, yes, this has been going on, I think, for far too long. 2 months, 6 weeks, 8 weeks, and the node hasn't gone down. He should have been biopsied. And here you can see, all right? You see all kinds of lymphoid. Here you see here is a good mantle, good reaction center. And you know that this is a reaction center because you can see the tingible body macrophages giving you this negative background, okay? And you see a lot of B cells that are just hanging around in the background, not forming any kind of follicles, which is very odd. And you can see large B cells in the interfollicular space, which probably are immunoblasts, which you can see over here. Now here is a a follicle. It has to be a follicle. There's nothing else because it's B. But there is something like a mantle, but there's no reaction center at all. Okay, it looks very different from this. This one looks as if it is dying out. It's like an atretic follicle. So you've got collections of B cells with large B cells forming clusters like that. You've got proper follicles with germinal centers and other things which do not have. It's a very strange kind of reaction. But one thing you know, it cannot be a lymphoma. It cannot be a B cell lymphoma. Anyway, okay? So, could it be a T cell lymphoma? Here is the CD3, and it's everywhere. The CD3 is just diffuse. It's small. These are not big B cells. And then again, you notice that there are these funny collections of maybe mantle cells, but they don't have germinal centers in the. They must be because this is a negative. It's not CD3, so it must be it must be something that is expressing CD20, which is not coming up over here. All right, you want to find out whether there are these are actually forming follicles, and the answer is yes. It's a very higgledy-piggledy formation. I told you, no, they are all odd-shaped follicles. They are B cell follicles, but they are very oddly shaped. And we know that they all have B cells in them. This is not just the, CD20 or this is CD23, both of them. Okay, so on one side you see odd-shaped follicles, then the other side you see this, and entrapped in them, here you see the mantle. Some of them have got large cells, but some of them have no cells in the center at all. Okay, and this is CD30, and you see the interfollicular cells are CD30 positive. So what is it? It's not likely to be a T cell lymphoma because the T cells are small and very evenly distributed. What kind of B cell lymphoma can it be? Do you think it's a follicular B cell lymphoma? Then you are not going to see these very odd-shaped follicles. And why should you see these very odd-shaped follicles? And this guy has had lymphadenopathy for 6 months. It is generalized, okay? All right, so then you have to ask yourself, very difficult to put this into any kind of lymphoma. What kind of reactive condition or benign condition can it be? And fortunately now we have the P24, which is the antigen. And you notice that P24 is exactly in the same distribution as your CD23. Okay, so P24 is expressed in follicular dendritic cells in patients who have HIV. So this guy had HIV-associated lymphadenopathy. So you had many different kinds of follicles. Some were atretic, that means they had collapsed. Some were just like normal follicles. Others were so ill-defined, as you can see by the way that, the follicular dendritic cells are outlined. Okay, so never forget that HIV is something that you have to keep in mind. In the days when we had this HIV lymphadenopathy, yes, we did P24, but at that time we did not have EBERs, okay, and EBV is not always the best way to show it. That means LMP, and therefore we never did the EBERs of this, but I'm just speculating. There may have been EBERs in those immunoblasts and P24 in this because yes, HIV by itself does produce a lymphadenopathy, but it is often associated with Epstein-Barr virus. Right, okay. Number 3. Now here, there is no prizes for guessing this thing because you can see something you have these pale areas that have, in some cases, almost bisected the node. One side you get pale areas, the other side you know that you've got something that is follicular. This was a biggish node, and many sections were taken, and you can see large pale area there. You can see that here as well, occupying almost the entire node and leaving just the medulla intact. You can see beautifully the medulla of the lymph node over here. When you look at the pale areas, you see that they are pale because the cells have got a lot of cytoplasm, so they're very unlikely to be lymphocytes. Of course, there are lymphocytes that are running around within this. And you also see some tingible body macrophages over here. So you can see a reaction center. And around that reaction center, you can't see a mantle so well. You see these pale cells. Now, what can be pale cells except for histiocytes? Okay, they don't look like lymphocytes, so they have to be histiocytes. And you look carefully, and then you begin to see apoptotic bodies. So there's no prizes for guessing this. The history is a 31-year-old female with multiple small firm lymph nodes on both sides of the neck with malaise, evening rise of temperature for the past 1 month. Blood investigations were normal. She had a slightly raised ESR, and there was a possible paracardiac shadow. The largest of the lymph nodes was biopsied, and I think the diagnosis is very obvious. Look at this.
Majority have answered Kikuchi's, ma'am.
Yes, of course it is Kikuchi's disease, but I want to show you what the immuno looks like. This is CD20, yeah. This is CD3, so there is a huge CD3 proliferation. CD20 is not, the B cell reaction is very poor. The CD3 reaction is huge, but you see that the pale areas are neither CD20 nor are they CD3. You do see a few CD3 cells in those pale areas, okay? But what you see is, when you look at this, there is much more CD8 than there is CD4. And CD68 marks those, CD68 is a marker for histiocytes, is marking those pale areas. And what you can do, if you have the ability, we do it in our lab almost by spinal reflex, you don't need to do it, is CD123, which marks the plasmacytoid dendritic cells. Okay, this was a case in which I don't know if you can see very well, this crescentic histiocytes. I don't think that they are very, even if they were there, I don't think they have been photographed adequately. But yes, you can see crescentic histiocytes and the plasmacytoid dendritic cells. So the diagnosis is histiocytic necrotizing lymphadenitis, okay? But every one of these should have a stain for AF being done, because the number of times, and I would say at least 10%, if not more, of the Kikuchis that we want to call Kikuchi have got tons of AFP, because Kikuchi is just a reaction. It is not a specific disease. We don't know what causes Kikuchis, and their non-reactive tuberculosis also gives you this kind of reaction. So this kind of histology. So you must do it, and also please find out if the patient is particularly, and almost I think maybe 80% of these are women, and therefore you should investigate for SLE. Now that SLE may be temporary or it may disappear, because Kikuchi is perhaps a viral disease, and you know that viral diseases can produce temporary SLE like arthritis and all of the other things. You can even get an ANA positive with the viral illness, and it sometimes lasts and you get a chronic SLE, or it just disappears and you're glad that you don't have it, okay? So it's a paracortical location. There is apoptosis, and I think you saw that paracortical thing. There's a lot of apoptosis, CD3, CD8 predominant. It'll have the CD8, 68 and plasmacytoid dendritic cells. Okay, now here is a 10-month-old female child. Patient had generalized lymphadenopathy and gradually increasing abdominal distension. splenomegaly, hepatomegaly, and wheezing for a short duration, no fever. And now you can see this. Now, anybody, I think, would agree that this lymph node is not very large. That's number one. I wouldn't be able to encompass it in one field. There are any number of reactive follicles. I mean, you can see that. There's the mantle, there is the germinal center. Everything is very obvious. So now, that's not a problem. But what is happening inside or in between this? You see almost as if the follicles are pushed apart by something that's happening in the interfollicular zone. And this is what is happening in the interfollicular zone. Here you can see that there is a mantle that I have photographed. There is a germinal center inside, and this is where you would expect to see T cells, or what you might call the interfollicular zone. The size of these lymphocytes, I don't know what the audience thinks, and maybe they can put it down that they want, okay, are not large. They are smallish or intermediate in size, okay? You can see they're vesicular, the nuclei are vesicular, and there are some chromocenters in these cells. I don't think that those are actually nuclei. You can see that better here. But what you can also see is, I can see that there are a lot of mitotic figures. Oh, so what is this funny thing where you can see nice reaction centers, and then the interfollicular space is full of these intermediate sized cells and lots of mitotic figures. Okay, so you can see that CD20, you can see the CD3, okay, and you say, oh, this has got generalized lymphadenopathy. So what will produce, what disease can give you generalized lymphadenopathy in a 10-month-old child with lots of mitotic figures? And the answer is, must be must be lymphoblastic lymphoma. But there, look at that. You can see the mitotic figures. They're all staring at you there. And there is no TDT. Oh, maybe the TDT is not being expressed. Let us do CD1A. Let us do CD34. Okay? Nothing. No CD1A, I'm telling you. And there is no CD34. So that's very odd. Okay? Young person, a young child, 10 months old, hepatosplenomegaly, diffuse proliferation of T cells in between reactive follicles, and very, very mitotically active, no TDT, no CD34. And then when you want to find out what are these lymphocytes, they're neither CD4, the T cells are neither CD4 nor CD8. So they are double negative T cells, okay? And this is, and you can then do a lymphocyte subset analysis on the blood, and this patient had double negative T cells in the blood, you can see that there, to a very large number, and this patient has what is called autoimmune lymphoproliferative syndrome. If you're not careful and you are not investigating this thing adequately, and the thing that you should, if you're not getting TDT or CD34 or any one of the immature T cell markers, then please think of autoimmune lymphoproliferative syndrome in a kit with liver, spleen, everything else, and you believe that this patient does have indeed lymphoblastic lymphoma. It is not, or an acute lymphocytic leukemia. All right. So this is autoimmune lymphoproliferative syndrome. Now I want you to tell me what this is. Somebody has got to give me this diagnosis in the chat box. I'm not going to, this is not this particular case. Okay, this is another case, and I'll tell you that this is an axillary lymph node. Anybody? So there is Dr. Bhakti, who has said
Leprosy.
leprosy. There is
Side of
somebody said crypto. Somebody said Rosai-Dorfman disease. Okay, I can see some of them. Fungal, cryptococcus. Yeah, I suppose any or all of these should be considered, because what you've got is a diffuse but scattered proliferation of these histiocytes. You can see the histiocytes, yes. But what I want you to see, and even in the H&E, what is in the cytoplasm of these histiocytes? Okay, you can see that there is this grayish, a kind of a grayish conglomerate of some sort. Okay, so whoever, you have to investigate this for, this is not Rosai-Dorfman disease, because that's not, you don't see emperipolesis. So whoever said Rosai-Dorfman disease was just sort of reacting just like that. There is no emperipolesis on the high part. Okay, so this thing is fight for for ARCO. So whoever, Bhakti, I think, was the first somebody who answered. So, full marks to Bhakti. This is leprosy. Okay, so this is not a histiocytosis. This is not something. This is leprosy. All right, good. So Hansen's disease of the lymph node. I'm not going to go into what are the features that are commonly associated with lymphomas, but you know that lymphomas crush. They often lack pleomorphism unless it is like an ALCL. High-grade lesions will have a lot of mitoses, and when they infiltrate into soft tissues outside of the lymph node, you often have this water through sieve pattern of infiltration. If it's a high-grade lymphoma, you might have infarction, and you hardly ever get these sort of things in lymphomas. Okay, now I was supposed to talk of lymphoreticular tissues. Okay, so now I just want to show you two cases, and you guys better tell me what these two cases are. Okay, here is an intussusception caused by a dark brown mass in the mesentery. And this is the dark brown mass that is in the mesentery. So somebody wants to tell me what is this dark brown mass in the mesentery, and I pointed out to some things. Yeah, so Rashmi, I see Rashmi Patnaik saying that it is spleen. Anybody else? You've got all these lymphoid, you want to call them nodules, follicles, whatever. Anybody else besides Rashmi Patnaik wants to answer the question? And why have I pointed out to this, to this capsule? It is absolutely typical. You see this kind of capsule. You never see this kind of capsule in a lymph node. So if you have this lymphoid tissue, okay, which is seen in a nodular, follicular, whatever word you want to use, pattern, and at low power you think, oh, there are some tingible body macrophages and all this, and I'm looking at a lymph node, for God's sake, just look at this capsule. And I marked this capsule, not only a capsule, but there are trabeculae that go into this organ through, starting at the capsule and right through it. That's why I've marked it. There are no lymph nodes that show you this kind of thick capsule. If that is the case, then the lymph node is abnormal, and there is some kind of fibrosis that is going on. Okay, so what is it? It's an ectopic spleen. And now you can see it's such a beautiful spleen, actually. Look at this capsule. There is no subcapsular sinus. I know that the spleen has lots of sinuses, but it doesn't have a subcapsular sinus. And what were these, what we call the white pulp? What were these little follicle things? All right, you notice that there is a arteriole which has penetrated into the center. These are not tingible body macrophages, okay? You see a dark zone around this arteriole, and you see a lighter zone around it. And then there is the red pulp, which is congested. In this case, you see the trabeculae going into the spleen. That is so typical, okay, of a spleen. And in the red pulp, yes, you see lots of lymphocytes that are present. There you see this. This is the arteriole, which has gone into this. It is arteriole because it's a small vessel and it has a thick muscular wall. Excellent. And you see this, there you see our arteriole and you see this. Now, let me tell you that if you go and actually investigate this by immunohistochemistry, you'll find something very interesting, okay? This is the white pulp, there's the arteriole. You notice there are no tingible body macrophages. So this is not follicular hyperplasia, which does happen. And if it does happen in the white pulp of the spleen. But this is not follicular hyperplasia because you do not see tingible body macrophages, which if you had bothered to go and do immunohistochemistry would have been CD10, the follicle center would have been CD10 positive and BCL2 negative. Okay, and you can see the red pulp on both sides. There is so much blood that formalin pigment has deposited over there. Now, this is not this particular case because nobody thought to do a CD3. But when you do a CD3, you notice this. I just took from an illustration which I have quoted over there. It's a nice article if you want to read it. It's an immunophenotypic approach to the spleen, in which you have this very. I really think that he's an excellent. He writes very well and he talks very well. That's Dennis O'Malley. So here is the arteriole. Okay. This is a spleen in which you actually do see reactive follicular hyperplasia. You can see that there's a mantle, okay, and you see germinal center. But what you see here when you do a CD3, you notice that the mantle is negative. You see some follicular helper T cells over there. You see this zone outside, which is negative in CD3, except for a few cells here. But what do you see around the follicle? There is a dense CD3 expression. So if you had to do that, if I had done it, okay, in this particular case, this zone, which is dark, would be CD3 positive, and what was at the periphery would be CD3 negative. That is the marginal zone of the spleen. So what is around the arteriole is a T. So there is a sleeve of T cells around the arteriole, and there is the marginal zone of the spleen outside of it. Now, the marginal zone of the spleen is a very interesting phenomenon, is a very interesting zone. The marginal zone of the spleen, although it looks lighter as compared to that arteriolar T cell, actually is you can compare it to the mantle zone of the lymph node. Mark my words, it is not the marginal zone of the lymph node, it is the mantle zone of the lymph node. You know why? Because that is part of the spleen which reacts to antigen, just like the mantle cell does, but this is in the spleen, it is a T-independent reaction. So whereas in the mantle zone of the lymph node, that is a T-dependent reaction, okay? You start to get the formation of germinal center where you have long-lasting antibodies, etc., being formed. That's not the same thing. Well, why do I say then that it is like the mantle zone? Well, it expresses IgD. So if you do all this, just go and do it. If some of you have the ability to do this, go and explore that, and you'll find that what we call the marginal zone of the spleen, and the only reason we call it the marginal zone is because it is outside the T zone. Okay, So the T zone is around the arteriole, and this is outside that, so we call it the marginal zone. Now, don't get confused. There's a marginal zone in the spleen. There is a marginal zone in the lymph node, which is outside the mandible. And mandible I'm talking about, the mantle. We don't see it very often. But I hope that, when Sumit is going to show you some cases that mimic Hodgkin's lymphoma, he will show you that particular condition in which you get a nice, marginal zone in a lymph node. If I ever get an opportunity to find one, that is good. Now, why did I show you CD8? It's interesting. You don't see it around in the T zone at all. That's the T zone, but it would be CD4, and there's no CD8 there. But look at where the CD8 is. See the CD8, where is it being expressed? Well, it's being expressed in the endothelial cells of the splenic sinusoids. And that is, therefore, when you have, tumors, vascular tumors arising within the spleen, expressing these markers, you should investigate CD8, because there is a very specific kind of vascular tumor that occurs in the spleen that expresses CD8. So let's see in the chat box who's going to tell me which is this. Oh, there comes RS says Sant. Would you like to expand Sant? Otherwise it looks like Sant, like saint. Yes, expand that word Sant. And Dr. Sriram has left the meeting. Okay, so Sant is not being expanded in that, but yes, there you are. Splenic adenomatoid nodular tumor. So this is why you get CD8 in this. All right, and this is my last case. I've talked for 2 hours now, but this is interesting because it tells you about the normal histology of another lymphoid organ. This is a 2-year-old female child who had fever, cough, snoring, and decreased air entry on the right side, and there was a huge anterior mediastinal mass, and we got a core biopsy of this mass. See, this is that kid, and there's hardly any lung over there that through which this poor kid could breathe. Yeah, huge anterior mediastinal mass, and this is the core biopsy. Okay, and immediately, even at this far, you can see something. What is it, the something that you can see? Come on, guys, you can see it. What is seen? Somebody see it. You want me to point it out? Here. Hassel's corpuscle. Excellent. Dr. Bhakti says Hassel's corpuscle. Yes. Okay. And away from the Hassel's corpuscle, you see very dense lymphocytes. Okay. And then there are some vascular structures over there. There are dense lymphocytes, and there are areas which, as you saw over there, seem to be in the less dense areas. See this? Very dense, less dense, and then you have the vascular structures over there. See, there is your Hassel's corpuscle at high power. You can see that? Here you don't see the lymphocytes as dense as you saw it in the others. Now, if you look at the immunohistochemistry, which of course we did, you can see the Hassel's corpuscles being marked with cytokeratin, and also there is a network of cytokeratin cells in that area, particularly in the area where you have the Hassel's corpuscles, and not much in the other areas. Okay. And what are the other areas showing you? A dense lot of lymphocytes, which are CD3 positive. Okay. Where the Hassel's corpuscles are, And where you were seeing a lot of this, of the cytokeratin, you see that there is CD20 being expressed. All right. So what is this thing now? Will anybody like to say Bhakti, who saw Hassel's corpuscles? What do you think that is? This is a core biopsy now of this huge mediastinal mass. Thymus. Dr. Bhakti says thymus. Yes, it is thymus, and that's what we called it. We called it normal thymic tissue, but it's huge. Right. So then we said that they had to do something about this case. So they operated it, and this is not the heart. This is that thymic tissue, right? It's huge. And now you want to see what it looks like. See, the dense lymphocytes and the less dense areas in which you see the Hassel's corpuscles, and you can see this like a cortex and a medulla. So everywhere there is a cortex and there is the medulla. And the medulla has the Hassel's corpuscles, and the cortex has these very dense, small lymphocytes. Yes? See, you can see that even better over here. Hassel's corpuscles, of course there are lymphocytes over there, but they are more widely spaced. And here the lymphocytes are, and everywhere you see these vascular structures. Yeah, that's the Hassel's corpuscles. Yes. So somebody now, Catherine Maria Joseph, says thymic hyperplasia. Full marks to Catherine Joseph. This is, yes, thymic hyperplasia. There are the Hassel's corpuscles. Here are the dense lymphocytes that are seen in areas where you don't have the medulla. Now see how beautiful it is. The medulla shows you a preponderance of CD20 positive cells, and you can see that the rest of it is not marked. The cortex shows you a preponderance of CD3 positive cells, and those CD3 positive cells are TDT positive. Okay, so what we have over here is thymic hyperplasia, but I'm glad that we have this thymic hyperplasia because I could show you the normal distribution of cells in lymphocytes in the thymus, the normal structure of the thymus. Okay, so this is massive thymic hyperplasia. It is massive. Okay, it's non-neoplastic, and this gives rise to an anterior mediastinal mass. And there are two types. One is true thymic hyperplasia, which this is, and the other is lymphoid follicular hyperplasia. And when you get lymphoid or follicular hyperplasia, it is the medulla with the B cells that are proliferating. Okay, and then you get follicular, and then you get germinal centers, you get mantles, and you get a classic follicular hyperplasia like you might even get in a lymph node. But it is present in the area of the medulla, not in the cortical part of the thymus. Okay, so if you get lymphoid follicles in germinal centers, irrespective of the size and weight of the thymus, it is follicular lymphoid hyperplasia, and it is, as you all know, associated with myasthenia gravis and other autoimmune conditions. Okay, and this is true thymic hyperplasia, which you might get massive hyperplasia or rebound hyperplasia, which happens with, in some of these things like Graves' disease, etc. But the histology of both these, rebound and massive, is the same. It resembles the normal thymus. Okay, so that's what, now this is my last slide, and I'm just going to give you a bird's eye view of what I've said. Okay, you need good histology and systematic evaluation of lymph node sections. Much of this is about lymph nodes because that's what you're going to see. Immunohistochemistry, a panel based on H&E evaluation. You must look for the cells of interest. You just can't lagao the, the immunohistochemistry, at random. It has to be done. And you need to know how to interpret this based on, normal and aberrant expression, and of course in a clinical context. And there are three kinds of mimics. I only talked about benign lesions that simulate lymphomas and vice versa. And I will tell you that T cell proliferations are difficult because they are polymorphous. You can't do, clonality assays on immunohistochemistry. Certainly, you can do it on flow cytometry, or on, you can do molecular biology. And let me tell you that immunohistochemistry does not solve all your problems. It might actually contribute to your problems. And simple stains, like we did in the fight for ARCO, they solve your problems. Okay, so now I think I have finished my presentation. I don't think that there is going to be much in the way of questions, but whatever questions, I'm very happy to take them.
Thank you for a very lucid talk, ma'am. We just have one question by the name of Aris, and they've said, how do you differentiate between a follicle and a nodule?
I don't think that there is, it's just a matter of terminology. There is no such thing. A follicle by usage, by convention, means that it must have, a B cell type of, you don't call something that is happening in a T cell thing a follicle. That's number one. So there should be B cells, although, as I said, that we are now talking about follicular helper T cell lesions, and there's some of them actually have a follicular appearance because they are within a follicle and they're growing within a follicle. Okay, so number one, by usage, it should have B cells. Okay, number two, they should be reasonably small. If you have very large things, sometimes you have very large follicular lymphomas. We call them follicles because we know they are follicular lymphomas, but for all practical purposes, they are nodular. Okay, so you have nodular lymphocyte predominance Hodgkin's. Okay, nodular lymphocyte predominance Hodgkin's starts inside a follicle, and yet we don't call it follicular Hodgkin lymphoma. Yeah, so it is about size and it is about cell content. I think this must be Sumit. Who's is this Sumit? Is this your?
Yes, ma'am.
Yeah, so he wants to show something. Sumit, please do.
Ma'am, one student has asked, can you please repeat normal distribution of CD5?
Normal distribution of CD5 is wherever there is CD3. That's the normal distribution of CD5 because it is expressed in T cells. Okay.
Anita, this is
normal. Yes, sorry.
for marginal zone. If basically this is.
If you want to show it, because I thought you might show.
I mean, I'll since you're talking about it, so
Yeah, can you just make it full screen?
Full screen.
it shows three balls. The central ball, which is light color, followed by a very blue color ball, mantle zones, and this less blue, pinkish of a prominent marginal zone. You don't get.
Yeah, you can see it, I think, better in one of your other follicles.
Yes,
Sumit. You have your you have a.
Yeah.
Okay, 1 minute. Maybe I can ask to annotate. Yeah, can you give me?
You asked the permission. I have not got your permission.
No, you can't give permission.
I have not
Okay,
received.
I will. Let me give myself.
Yeah.
permission. All right.
Yeah.
All right. Now, yes, here it is better. This is the germinal center. That is the mantle, and you have no. Show me your previous
Yeah.
slide.
One sec.
If you have a good, I don't
I
want
will have
to preempt your talk, but if you have one of your good.
I'm not able to actually go out. How do I? One sec. I'm stuck here. Stop one sec.
You're stuck.
Yeah, no, it's okay. I think I'll show it in my talk. Maybe I'm not
Yes,
able
please do that. Particularly, you have one of the things that begins with T and ends with S.
Yes.
I thought that you might show it,
Yeah,
and
yeah,
that's why I didn't show it over here. Otherwise, it becomes repetitive.
Yeah.
Okay, sorry. Is there any other question?
Ma'am.
If not, then it will. I'm sure if there are questions that come to your mind, you can always send me an email and I will answer it. Or you can ask it to Sumit when he's talking about Hodgkin's, or you can please ask it to Dr. Natkunam,
Yeah.
and she will answer it.
Thursday
Okay?
we have.
Yeah. So I went slow and I showed you many things because I felt the people who don't do immunohistochemistry sometimes think that it is a panacea, but it is not. Panacea means a cure-all, but it isn't. You have to really look at histology slides to be able to do that. And so you will see a whole range of them now from the next talk, which is on Thursday, and when Sumit takes his next Tuesday, right? Sumit?
Yeah, yes.
Yeah. Okay. I don't know whether I'll be able to attend this Yashoda's because I'm in Calcutta at a meeting, but I'll try.
There is one more question which has
Yeah.
come up.
Yeah.
Somebody is asking that are there no helper T cells in the mantle zone? Is it only in the germinal center?
It's mostly in the germinal centers. Of course, there are T cells in the mantle zone, and they would be follicular helper, but where are they? They are concentrated in the germinal centers, because when you have antigen presentation over there, it's the T cells that are helping these follicular center cells to reach their the epitome of their ability to make the right kind of antibody that is very specific. So they are concentrated in the zone. Of course, they are in the mantle zone.
That's it, ma'am. No more questions for now.
Questions? All right, good. So everybody can go and have